I got this DM from a follower, and this is a common question that I get asked every day in my practice by my patients and by people on this app. So let's get into it. She's someone who is 30 years old and has had 3 chemical pregnancies in a row, and she's wondering what she can do to prevent this happening again. She says that she has a very healthy diet, maybe could make some lifestyle changes, but wants to know why she's prone to chemical pregnancies. The most common cause of first trimester miscarriages, and yes, biochemical pregnancy loss counts, is chromosomal imbalances or errors, which can happen to anyone. Even in your 20s, 20 to 25% of embryos are going to have typos and be missing or have extra DNA. And at 30, it could be, around 30%. Now, it is strange for someone to have this history 3 times in a row at age 30. So it is important to not hand wave and just assume, oh, these are just errors. We know maybe your egg quality isn't what we think it should be at age 30, right? There are many factors that could affect that. And there is no direct way to test egg quality. So that's also a possibility, and all we can do is speculate about that. So could you fall on the 30% side of that split 3 times in a row? For sure. There are times that you're ovulating an abnormal egg and you didn't even know about it because that embryo didn't even have the chance to implant. And so you just didn't get pregnant that month. But if a pregnancy occurs, then the most likely fate is these early first trimester miscarriages. Now, outside of embryo-related causes, it's important to rule out other external factors that could predispose you to recurrent pregnancy loss. So the first thing is a karyotype for both you and your partner, because that's going to help you figure out whether there's any structural rearrangements in your chromosomes that could lead to a higher than expected rate of forming abnormal embryos. So this is a blood test. It usually takes 3 or 4 weeks to get the results back, and this is not done like your regular carrier screening. Most people do not have karyotypes drawn just as a routine measure. This is a specialized test that you have to make sure you're getting, and it's not just about you, it's about your partner as well, because you need to be looking at both people that are contributing to the chromosomes of your embryos. I would also look into a disorder called antiphospholipid syndrome, and this is blood work looking for markers. So if these markers are elevated, even 1 out of the 3 that you test, then you're going to want to be on baby aspirin while trying to conceive, and once you have a positive pregnancy test, we add an injectable blood thinner to prevent recurrence. And then looking at the structure of the reproductive tract is extremely common. I will tell you that there are so many cases where patients have recurrent biochemical losses, and they come to me and I do an HSG and find that they have a hydrosalpinx, where the tube is dilated and has toxic fluid building up in it, which is communicating directly with the uterine cavity and can double your risk of miscarriage and lower your chance of implantation by 50%. So anyone who's got repetitive failed transfers or recurrent losses, especially these early biochemical losses, I never fail to get an HSG to investigate not only their uterine cavity and their tubes. And if the HSG doesn't give you a very clear view of the uterine cavity, I might add on a saline sonogram. It's also not wrong empirically to do a hysteroscopy so you can get a direct look at the uterine cavity, but that might not be a necessary step if you can get good imaging first. And then there's lower yield things that I test. I'll look at thyroid function. We will also, in addition to doing a semen analysis, do sperm DNA fragmentation testing, because that, while it has weaker evidence, is now considered a potential contributor. So that is what I do as part of the battery of tests for the recurrent pregnancy loss workup. And it's important to be mentally prepared that 50% of individuals or couples who undergo these panels of tests will have all normal testing. And that can be really frustrating because it can be very gratifying when you find a target to treat. But I always remind patients, look, at the end of the day, these might have just been chromosomally abnormal embryos, and that is not something that we're testing for directly. It's good if you rule out karyotype abnormalities, because then you know there's no reason that you should have an abnormally high rate of abnormal embryos. But remember, we don't know what your underlying egg quality and therefore resulting embryo quality is, because there's no way to directly test that. So you can then operate under the assumption that these were likely genetic errors. And there are things that you can do about that. I've had patients with a completely negative RPL workup, recurrent pregnancy loss workup, who then opted to do IVF because they wanted to make use of pre-implantation genetic testing of the embryos so they could select an embryo that they knew was genetically normal for transfer. And that strategy works well for a lot of people. So just know that there's lots of tests. And if you talk to your doctor and they just are dismissive at all and don't want to do these tests, then get another opinion, see someone else, but you should really have a complete workup.